I am very joyful. It is precious that each and every one of you is on Medical College for the 7th International Symposium of New Frontiers in Cardiovascular Research. Ladies and gentlemen, the flexible, this meeting will provide us natural opportunities to discuss policies and procedures, share knowledge and insights without that all around the world. I would like to take this opportunity to let each and every one of you know that we are streaming online. So if anybody would like to join us there, please
Jesus and so on, when all increase the way. As an increasing, there is good economic knowledge. It's the guideline of the university focus. It's a very important knowledge from the new perspective. It's a demonstration of the University of Giessen. It's a engaging energy from its design. Life is a symbol of directing, valuing, and abundance, like virtual business knowledge. So I request the delegates on cities to join us to the lab.
Now, I would like to call upon Dr. A.B. Principal SSRIC to address the audience.
Yes, good morning to all. Also, the very personal law. Also, the very beginning. Also, the last this year. The Sunday of power. The release. The release, guests, media personnel, members, dear students, and our everyone. And students who are online in YouTube. The usually straight, organizing and hosting the 7th International Symposium of New Generation Cardiovascular Research in Mauritius, via SSR. The SSR Medical College is run by Indian Ocean Medical Institute Trust, established by Honorable Sri R.P. Singh, and already successfully producing world-class doctors. For the last 50 years, we are in our silver jubilee year. We celebrate silver jubilee. Next, 18 September 2024. This is the first medical college in the Mauritius, established in 1999. And we have produced more than 1,822 MBBS graduates who have contributed to the sterling success of hospitals and medical institutes in the world in various countries, including USA, UK, Canada, Ireland, France, Germany, Australia, New Zealand, Singapore, Japan. And the largest numbers are in South Africa. The college is affiliated to University of Mauritius and recognized by medical council. And this is how medical college is experiencing a proud moment as it hosts an international symposium showcasing its commitment to global medical collaboration and knowledge. This event brings together experts from around the world, boosting innovation and excellence in therapy. This kind of international collaboration will help improve the quality of healthcare in Mauritius. I extend my heartfelt thanks to our Honorable Chairman, Giessen, for graciously providing us with the opportunity to create on organizations, prestigious international human rights. I would also like to express my gratitude to the dedicated board and local organizing committees. In recognition to his dedication and effort, I would like to extend my special thanks to the team, planning and coordinating and executing this of studying international symposium. I acknowledge and thank our local organizing members, Dr. Rama Professor, Dr. I appreciate and thank all our international volunteers who are working tirelessly for say, I appreciate and also thank our chairman of this CED and judging for their untiring efforts. So again, I welcome all the delegates to the 7th International Symposium of Giessen Cardiovascular Research and wish you all a productive and enjoyable experience.
Thank you, sir. I would like to call upon Dr. Nina to hand over the abstract for the event to Dr. Giessen. So I kindly request you to release the abstract. May I kindly request all the distinguished guests on the stage to kindly take their seats along with the audience.
Ladies and gentlemen, without further ado, let's begin our evening session. The chair for this session is Dr. Seewoosagur. Dr. Singh is an alumni of the prestigious SMS 24. He has completed post-graduation in PhD. Professor Singh has 33 years of teaching studies for medical students at various places of work. He joined the Institute of Medical College in the year 2006 as a principal and head of the department. He He is a member of the National Society of India, as well as the International Association of Medical and Biomedical Research. Some of his publications include estimating the cycle of the incident of epidemic and population population. It is related to hospital for the 46 science international. So I request you to take this. So I request you to take this.
I follow on with Professor Dr. Giessen and IPDF and Justus.
What is your comment?
Let's show upon Professor House.
I'm the only one see that and we have of the ways having some college staying professor strategy focusing us we know that the cardiovascular disease in both disability worldwide and new treatments that we need to and I think it's aiming with this meeting, we said Europe, Germany, Turkey, UK, South Africa, Singapore, and bringing together special researchers, and we look to inspire our future doctors and students as some approach, and this is my foremost right opportunity and finally, a personal really of experience with academic solutions and I'm also it's really great for the students to have this meeting. So I hope you will in the next few days conference and hopefully it's my question. Thank you.
Welcome, Professor Flowers, please come.
Good morning, everyone. So, thanks, first of all, to your words. First, weeks, months, great thank you for organizing it and to spread the share of cardiovascular research. They've got in touch, specialists, also order to then have visits rural. It's now a jazz song from the 1930s, describes like points see goes like with a slight contributions. The melody of four hands with this kind of impression and feel for based on customers and also the students of the what is the base things for people here.
Yes, delegates tables from the courses is standard delegates from the school courses is the documents in school and management. On the way of corporacy of the reserve like on through this period of 17 national symposium of new party research. It is great privilege for all of us to host this event in the school. In collaboration of the communities of the world in the University College Management. This is University Germany, Duke-NUS Medical School Singapore, Guiding Center Mauritius, and Cardiovascular Mauritius. It is immense pride and enthusiasm that we gather and share knowledge, foster collaboration, and advance our understanding of cardiovascular. This international symposium features distinguished speakers here from different countries of the world, in the Hungary, Singapore, South Africa, Germany, USA, UK, Australia, Turkey, and of course Mauritius. Who will be providing valuable perspective on country research, clinical breakthroughs, and innovative treatment. The clear goal of improving cardiovascular care populations of Mauritius. With the diverse sessions and discussion, we aim to address the most pressing issues and health developments in Cardiovascular. This symposium also includes young investigation and oral presentation for the students from Sister Medical School who will be showcasing their research in the field of cardiovascular. And it will give a valuable experience to them in evidence-based medicine and in research and create a strong foundation for their future medical patients. So I like to thank all the delegates for participating for results and to report again. And then I will extend my gratitude to the Honorable Chairman of the Medical School, Mr. Arvind Singh, for providing us an opportunity to host us event at our medical college. I have to thank the four organizing committee members, especially Dr. Glenn, Professor Thompson, Mr. Fox, for collaborating with us, and also the Sanjay from the Cardiovascular Society of Mauritius and Dr. Ganesh from the Cardiac Center, and all the members who were speakers who were here today and the chairs. It all started about a year ago when I received an email from Professor Derek, two Dereks, Professor Derek Mouseway and Professor Derek Giessen. So we are very excited and it's like a dream and this is the day that it's a real thing that in true for us. And I have to especially thanks for his encouragement and unwavering support in organizing the event. I thank the whole organizing committee, Dr. Paras,
Ramgoolam, Dr. Rama, Russian, he's not here because he's not well today. Younger, and all the faculty members. And then I have to thank all the students. Round of applause for the students. Our management team, and lastly, all the volunteers. Thank you.
Ladies and gentlemen, we started with a few minutes. So the speaker for the session is Professor Dr. Kelvin. Dr. Kelvin is a professor of molecular and cellular cardiology at the University College-Mauritius and is the director of the Cardiovascular Institute at UCL and UCL Hospital. He was the vice president of the British Cardiovascular Society and chairman of the Cellular Biology Working Group of the European Society of Cardiology. In the year 1994, he was awarded the Doctorate in Science for his substantial contribution to the knowledge of cardiovascular disease and treatment. In 2013, he was awarded a second Doctorate in Science, an honoris causa from the University of Cape Town, in recognition of his distinguished basic and clinical research in the mechanisms underlying myocardial protection. He is also a professor in the Department of Medicine at the University of Cape Town in South Africa, as well as the University of South Alabama, USA, and North China at Cole Medical University. He is on the editorial board of many cardiovascular journals and has published more than 600 papers. Professor Yellen runs a transitional research institute at the University College of London. His main research interest being protecting the heart and brain from ischemia, reperfusion injury in both the basic and clinical arena. It brings me great honor to welcome Dr. Ellen onto the stage.
Thank you very much for your kind introduction. And this microphone. Very much. Thanks. Today is on protecting the heart from the speed from the extrovert side. And let's wait to start this by a short introduction. And well known, most of us in this room, that ischemic heart disease is the leading cause of death worldwide. And its major two manifestations of myocardial infarction. And the most effective way of reducing the size of the evolving infarct and improving outcome in patients is timely and effective reperfusion. However, it's important to note that the benefits of these reperfusion strategies are indeed mitigated by something called reperfusion-induced injury. And therefore, this so-called reperfusion injury provides a target for further reducing the size of the evolving myocardial infarction. And so strategies to protect the heart against reperfusion injury will be discussed over the next 25-30 minutes. To give you a better understanding, what we're trying to do is that if you look at this following slide, you will note that there's a picture on your right up there that's showing you what happens if you ligate a coronary artery in an animal, whatever the case may be. And depending on the collateral flow, you'll get virtually a fully transmural infarct if you can see this in white. So therefore, the most important thing you do is to reperfuse that. And if you reperfuse this heart, by the way, this is slices of a rabbit's heart. Part of the remaining 30% here is due to reperfusion injury. So you get much better protection, but you don't get full protection at all. And we have argued over the years that if you add additional targeted therapy, you could prevent reperfusion injury by a further 20%. And that's the essence of what I'm going to be discussing today. So the question is, can we protect the heart against ischemia as well as lethal reperfusion injury? And there's two concepts here. One is called ischemic preconditioning, which I'll discuss in a minute, and one is called pharmacological preconditioning. So what is ischemic preconditioning? Well, very simply, again, if you look at this slide up on your left there, you will note that if you stop blood flow and you don't do anything, you don't reperfuse, you stop blood flow for 30 minutes, so a lethal infarct, you can see you get a virtually fully transmural infarct and that heart will never recover. However, the fascinating subject of conditioning came up in 1986 by Reimer, Jennings, and Murray, who showed that if you stop and return blood flow with sublethal periods of ischemia, just 3 or 4 minutes of ischemia with reperfusion before the lethal ischemic insult, you can get a significant protection. And you can see quite clearly on the right there that this heart is in a much better state than the one on the left. On the right, left, I'm getting confused with my picture here. So we came up with a number of hypotheses to see if we can look at this in detail. And the initial hypothesis was activating survival pathways which exist in the heart, such as activating AKT and ERK kinase, and also activating various anti-apoptotic processes could protect the heart from reperfusion injury. And that in turn would inhibit a pore on the mitochondria, which will reduce ultimately the size of the evolving myocardial infarction. And there were 3, you don't have to read this in any detail, but there were 3 papers that we published at various times with 3 hypotheses to look at this. And the first one is there a role for growth factor signaling? So hypothesis 1 was as follows. We surmise that if you activate growth factors, and there are loads of growth factors, insulin is a growth factor for argument's sake, that in turn would activate or phosphorylate a kinase, which would then be anti-apoptotic and phosphorylate something called a protein called BAG. Likewise, if you activated ERK 42, 44, that in turn would inhibit caspase 3 and be anti-apoptotic. So all of these things we said would target the mitochondria and cause the cell to survive. To show you in more detail about how this all started, the first study we looked at was a compound called urocortin. Now, urocortin is a growth factor and belongs to the corticotropin releasing family of proteins. And you can see here that if we activate urocortin, and this is the model we use, on the right there you can see an isolated perfused rat heart, where we anesthetize the rat, we remove the heart, we retrograde and perfuse it via the aorta, and that little heart goes on beating for hours. We can put a suture around the coronary artery, ligate it for, say, 30 minutes to make it ischemic, and then reperfuse it for a few hours. And you can see on the slide itself that if in a control heart that we don't do anything to, we just get 30 minutes of ischemia, you get about 50% of the ischemic zone, of the risk area, infarcting. If you gave this drug urocortin, which is the growth factor, which is part of what we were testing, you can see you get significant protection, down to about 20%. And if you give drugs that inhibit one of the pathways, the 42, 44 pathway, you abolish the protection, indicating that by using this type of pharmacology, you could get protection, and it was involved this survival pathway. To look at it in a more specific way, and this looks a complicated slide, but just concentrate on the arrows down below in blue. After 5 minutes of ischemia, you get a reperfusion, you get some recovery. If you gave urocortin here in red, you get a significant recovery, giving you reporting at the moment of reperfusion. Likewise, that stays up for 10 minutes, 20 minutes. And then it's this survival pathway is activated and lasts approximately 20 minutes. And we wrote this paper back in a while back in 2000 and whatever, 2002. And all we said was we believe that the heart possesses pro-survival, we call reperfusion injury salvage kinase pathways or risk pathway that may be exploited when developing agents that protect the heart. So that was our first hypothesis, and when we came up with this so-called risk pathway. And this risk pathway, this reperfusion injury salvage kinase pathway, can either be activated by preconditioning or it can be activated by loads of various drugs. And I'll show you your reporting, but it can be activated by insulin, bradykinin, etc., etc. The third hypothesis was, would signaling through this pathway linked to the mitochondrial core? And this is where Sean Davidson is sitting in the far right hand in the part at that time. And what we did, or what Sean did, was he took rat mouse hides, he loaded them with a fluorescent dye called TMRM for 15 minutes. He then stimulated them with a laser to generate ROS, reactive oxygen species, free radicals, within the mitochondria. And that caused the opening of the pore. And measured the time to depolarization or the time to subsequent rigor was recorded. And if you just look at the right, at the contracture on the right, probably easier, you can see with insulin, you get a much longer delay in the time to contracture compared to control. And if you give drugs that inhibit insulin, you can abolish the protective effect. It's just drugs called LY and Ortman, and they abolish the survival pathway. And that links the signaling pathway, the risk pathway, to the mitochondria. These were isolated mitochondria. So we came up with the conclusion that activating the so-called risk pathway and inhibiting the opening of the pore are effective ways in reducing ischemia reperfusion injury. And I have to add, this was in young, disease-free animals. Now, that's not what happens in man. And I think Peter Ferdinandi would back me up on this because he's done a lot of work in this area as well. So we wanted to consider comorbidities. Can we take animals with comorbidities, diabetes, hypertension, obesity, etc.? And what would be the status if we tried to precondition them? So here's an example of one of the studies we did with rats. And we looked at age. Age itself, as we well know, is a comorbidity. And if you look at a normal animal, the ones we all use in laboratories, you can see that you can precondition with either one cycle of ischemia, short cycle, or 3 short cycles. And you'll get significant protection against infarction compared to the control. As the animal gets older, you can see one cycle doesn't seem to do the trick. You have to use 3 cycles. You have to stimulate the survival pathway even more. And then when you get to the really aged animal, here, you can see that's the old animal, about 18 months to 80, 90-year-old. It's very difficult to precondition, either with 1 cycle or just about 15 cycles, not really. So we must take that into account when we think you're treating man. What about going from animals to humans? Well, we're very fortunate at University College. We have a close link with our cardiovascular team, and when they put a line into the right atrium when they do coronary artery bypass surgery, they have to, by definition, take off some of the atrial appendage here. And what happens is we stand by with a pot of buffer, cold buffer. We collect the atrial appendage, as you can see here, and we take out these little atrial strips. And that's the type of equipment we use. I'm just only showing you that to show it looks very fancy, but if you home in there, you can see that that is a piece of human muscle taken from a patient 20, 30 minutes earlier and that's, we can stimulate it, but it's viable, it's alive, and we have ethics of the approval to do all these studies. Can we precondition a human? It's all very well shown we can precondition the animal, but can we precondition the human? So, and again, can we precondition the human with diabetes? So we took atrial trabeculae from patients who are diabetic and patients who are non-diabetic. And in the non-diabetic controls, when we subject that piece of muscle to a period of hypoxia and reoxygenation, we only get about 25% recovery function. When we take this non-diabetic and we precondition it with a short burst of hypoxia and reoxygenation, we get a significant protection. When we take diabetic muscle from a patient with type 2 diabetes and we try and precondition it, we can't. So that's important. Why can't we use 4 minutes of hypoxia and 7 minutes of reoxygenation as our preconditioning stimulus? When we make a more intense preconditioning, we appear to be able to protect. And we think that's all to do with activating a significant amount of the survival protein. And to show you that, these are human muscles, and we looked at the diabetic, where the amount of phosphorylated AKT is significantly less than that in the non-diabetic. Excuse me. So the survival pathway is down-regulated to a certain extent. So we asked the question, are we not obtaining sufficient activation of the survival pathway? Why? So is it time now to optimize the pro-survival of this pathway? And this PI3 kinase pathway that we're interested in, has 3 isoforms, an alpha, beta, and a gamma. And we started working on it to see activating a specific isoform would give us a better protection. So here's a study done in rats, again, in normal rats, by a PhD student of mine called Rosello. And he very simply took an in vivo animal rat, ligated the coronary artery of the left ventricle here, and he looked at the control of the 30-minute ischemia, and he found it 60% infarction. When he preconditioned, he got a significant benefit. But when he preconditioned with this highly specific antagonist of the alpha isoform, he abolished the detection. So in other words, implying that the alpha isoform was the important isoform of the 3. With that, we said, is developing the PI3 kinase alpha the way to go forward? Is that how we should go forward? So if you think about it, for those of you who might have a cancer bias in this room or work in the cancer area, you know that in the cancer area on the right, you want to inhibit PI3 kinase. You want to inhibit that growth factor because, and that's a lot of anti-cancer drugs are inhibitors of the PI3 kinase. We, on the other hand, on the left-hand side, want to activate. So you argue, is there some problem in the two? But we only want to activate it for a few minutes. It's not as if you're going to give chronic treatment. So we went to our cancer group at the hospital and said, can we get hold of a PI3 kinase alpha agonist? And nobody had that. But fortunately, we went to a high throughput screen with AstraZeneca. They had a screening library as part of their open innovation program. And we screened 450,000 compounds and identified a number of potential PI3 kinase alpha activators. And then we spoke to the UCL medical chemistry department, and we used to increase the potency of this drug. And it was basically led to the development of something called 1938. That was the name that they gave it. And we've kept that name. And you can see when we use mass spectroscopy to identify the binding pocket, which is present here on the alpha, in PI3 kinase alpha, and you can see that with the arrows pointing, but not in PI3 kinase delta and not in beta. So it's specific for PI3 kinase alpha. So we decided, let's test it. Let's go back to the animal model, let's test it. So we tested it in vivo and in vitro, and I don't want to spend too much time, but very simply, it was very exciting when we gave this 1938 to animals that had a ligation of their coronary artery followed by reperfusion. You give the drug at reperfusion, you get significant protection, and you activate this kinase. And we were very excited because we managed to publish this paper in June this year in Nature. I'm going to show you some data on this slide, which is nothing to do with the Nature paper, but because we were so excited and we were also interested in ischemia reperfusion injury in the brain, because ischemic stroke is not too dissimilar to the acute myocardial infarction in terms of the pathophysiology. You have to reperfuse, say, muscle or say brain. We looked at this, and this is not published. We looked at this in a model that we have of coronary artery, middle cerebral coronary artery occlusion in the brain, and we can show that giving this drug, this is just a pilot data. I just wanted to share this with you. Pilot data showing that this particular 1938 can protect the brain as well. So we've got a lot of work to do on that, which we're doing at the moment. So it looks like 1938 is potentially, and I use the word potentially, exciting way forward, which maybe hopefully we can discuss in the years to come. But let's return, if you don't mind, I'll show you some of the basic stuff we do. I want to return to the current clinical situation or the clinical program. I showed you this slide right at the beginning, which showed you how powerful preconditioning is in the animal setting. However, you can't precondition patients using this technique. You can't ligate an artery, and it would never get ethical approval for anything like that. It's not practical. Potentially it's dangerous. So we've got to find another way to protect the preconditioned patient. And that's the question. Is there a non-invasive way to condition animal and human? And this led to the phenomenon of momentous, which was initially developed by a group, Karen Trishik in the United States. We've also done quite a lot of work on this. And very simply, if you inflate and deflate the blood pressure cuff on the arm to reduce hypoxia and then reoxygenation, this leads to activation of pro-survival pathways of the ones I've been talking about. And they can trigger protection. So you can trigger protection in the heart, the kidneys, and indeed the brain. This form of remote conditioning. It's non-invasive, low-cost treatment, and I'll show you some work we did here in Mauritius a few years back on this in a few slides at that time. But when you do clinical research, there's different ways to before you get to the clinic, you've got to look at the pre-clinical studies. I'll show you some of those. Then you've got to do proof of concept with patients, which are using, these are not outcome studies, these are soft endpoints. And then you've got to do the final arbiter is the multi-center randomized trial. So let me just quickly, very briefly show you, don't look at the slide, you want to see it properly. But it's a preclinical study, a meta-analysis we did on all the preclinical studies over the years, looking at remote conditioning. And the bottom line is it significantly reduces infarct size in animals. Moving on to the proof of concept, we looked at a range of studies. And here again, I don't expect you to read any of that other than to know that using soft endpoints, these are not hard endpoints, proof of concept said significantly reduced myocardial injury in these type of studies. So it was very exciting. So myself and Derek Hausenloy and Hans-Erik Botke in Denmark put together a study, a multi-center study to investigate this. So in other words, we had to jump from the proof of concept, because we were all excited by this, to a large multi-center randomized outcome trial. And that was called the to Eric PPCI. Don't worry about the title. I sometimes wonder how we got that title. But anyway, it was looking at the effect of remote ischemic conditioning on clinical outcomes in patients with myocardial infarction. There were 33 centers in Europe. They covered Denmark, Spain, Serbia, and the United Kingdom. And the trial had over 5,000 patients, and the final analysis was 2,500 or so in each group. And when we analyzed the data and broke the code, I remember in my office, we were all excited, only to find that this did not improve clinical outcomes. And the clinical outcomes, cardiac death and heart failure for heart failure. So that's why you do research, and that's why you do a clinical study, if you're doing that type of research. It didn't show any benefit. It was neutral. So we thought about it, and we wrote this up and published this in the Lancet. And the question is why? And the answer, we think, is the following. The patients that we looked at in the control group, in cardiac death in the control group, was 2.7%. And we would argue, all of us in this room, that 2.7% is so low that what are you going to protect against? There's nothing to protect. And the human is already in a virtually, but argue, protected state. Bearing in mind that in Europe, they get primary PCR very, very quickly, etc. Secondly, 96% of the patients presented with no symptoms or signs of heart failure. So very low risk. The total acute myocardial time was very short, up to 3 hours. Now, the patients were there within 3 hours. They were having their primary PCR. And the prevalence of cardiovascular risk factors in Europe was low. 40% of patients with hypertension and 10% with type 2 diabetes. And you know straight away, I'll show you that in Mauritius, it's up to about 40% type 2 diabetes. So the whole argument here was the patient population that we chose to do this study. And now I have to be, we were applauded for the study because it was a very well-designed study, but it was neutral. And then we believe the reason it was neutral was very low-risk patients in developed countries. Let me show you this slide. I'm almost done now. This is what's happened in cardiovascular medicine since we all started. On the front row here. There was lysis, there was ACE inhibitors, all introducing all ability to lower mortality in patients who present with ischemia. However, in developing countries, this is not quite the same. The target is still there. So with that in mind, we said there remains potential to improve clinical outcomes in high-risk ischemic patients, especially in low and middle income developing countries, such as Africa. Because in the developing countries, insufficient access to hospital facilities, especially in rural areas, prolonged transfer times, 70% of patients present in over 6 hours. Most of the procedures used are still thrombolysis, and bearing in mind thrombolysis dissolves the clot. I keep using the analogy, it's like an ice cream that melts. It's slow dissolving of the clot, and while the clot is dissolving, muscle is still dying. So it's a good process, but it's not ideal. And there's also limited use of secondary prevention therapies such as antiplatelets, beta blockers, renin-angiotensin, etc., for improving clinical outcomes. And of course, as I mentioned a few seconds ago, there's increased prevalence of risk factors such as hypertension, diabetes, etc. So what I'm trying to get across is that these are high-risk patients, which we need to now see whether the right conditions can protect them. And there is a precedent for this. And mentioned the front row here, part of the study we did in 2015, and we worked with our cardiology colleagues. And we did a study in patients. And this was a proof of concept study. So it wasn't an outcome study. So these are relatively, well, I'll show you now what I mean by that. All the patients were treated with thrombolysis. That was the paper we published, and some of the people will recognize their names in here. And you can see very quickly, in this study, in a multi-ethnic developing country. We used 5 hospitals, 250 odd patients in a group, and we reduced infarct size by 80%. As again, these are soft endpoints looking at troponin T, but they gave us encouragement that these were high-risk patients and you could protect their myocardium. So with that in mind, we've developed a multi-center study in Africa. We've started the study as a proof of concept to see if we can work with different African countries. So at the moment, we're working with South Africa, Sudan, Uganda, and Kenya. We've recruited over 200 patients. We're bringing in other countries now to try and get our patient population to increase. We've written major grants to grant awarding bodies to support the study. We've bringing in Tunisia, Ivory Coast, Mozambique, and Senegal have all agreed. And sorry, I'm desperately trying to get Mauritius to join us because they know they can do the study. They prove they can do the study. They've sent papers. So I'm hoping that within the next few months. With that in mind, let me conclude just by saying that this RIC Africa study, which we call, it's not a sub-Saharan anymore. It's going to be an Africa-wide study looking at multi-sector randomized clinical trial. It's designed to test the impact of this phenomenon of remote preconditioning on the composite endpoint of 30-day mortality and heart failure in 1,200 patients. It's going to be using patients who present and receive thrombolytic within 12 hours, and the participants will receive this remote as outlined there. So in summary, protecting the heart from ischemic reperfusion injury is still a major target. Our understanding of the pathophysiology of ischemic reperfusion and causes of cell death has been significant over the last 20 years. And although this risk pathway that I mentioned to you is important and clearly protects the heart from ischemic reperfusion, it may be time to optimize and find out exactly how it works and using the right isoform of activation pathways. And that might work with the development of this drug called 1938. However, the multi-target approach is still something that's important, which we don't seem to do. It's targeting different forms of cell death, DNA repair, which gets down to specifically inflammation. So until we sort out also the disconnect between basic and clinical research, which all should not progress, we've got to change our way we think of using animal studies. We've got to make them much more clinically relevant. With that in mind, I'll stop there and thank all our supporters, funding wise bodies for their support. And that's where we sit in anybody's speaking. Thank you very much for your time.
So wonderful presentation, Dr. Derek. Very impressive. Now, floor is open for questions.
It's always difficult when you see your colleagues asking you questions. I think they should be allowed.
Hi, Prof. Thanks for that fantastic talk. And it's great to see the risk pathway going from the bench, and now you have a therapeutic agent. A couple of quick questions. The PI3 kinase activator, what's the next step to try and translate that into the clinic? And the second one is, have you considered combining the PI3 kinase activator with other cardioprotective agents to see if you get additive protection? Thanks.
Your first question, your second question, yes, we are considering combining it. Your first question was, what's the next step? We're looking at it in the human muscle. Patient is still a way away. I think we have to accept that. We've got to prove that everything that's the advantage, as you well know, of having this human muscle, is we can see the signaling pathways in the animal are also the same. Admittedly, it's atrial, not ventricle. It's very difficult to get them. And that would be and we've got to look at this 1938 and redefine it. Sean and I talk every day about it. But I think those are the next simple steps.
Yes, thank you very much for this great talk. You started out with the experimental procedure, so to say, in preclinical models for the preconditioning. So the treatment before interventional procedures. Now, there's also post-conditioning procedures to use. Would this be a valuable alternative, perhaps also in patients?
Actually, thank you, Cloud. You sort of hit the nail on the head. When I said pharmacological preconditioning, I should have said pharmacological post-conditioning, because I don't think we'll ever use, we might use it, but I think it's the idea is to give a drug at the moment of reperfusion. So if the patient presents, it's in an ambulance or they're taken to the hospital, if this is all working, the drug will be given forward to open up. And during the opening of the artery. So it's sort of a post-treatment.
Okay.
Bearing in mind, of course, that all animals, most of them, and humans, have a significant lateral flow. So they are being refused themselves. Not so, you know, it is sort of a post-treatment thing.
Hi, Sean Jackson, Sydney. It was fascinating talk that you gave. I want to ask you many of my cardiology colleagues, their biggest concern is you open the epicardial artery and you have no reflow or hypoperfusion. And microvascular hypoperfusion is not uncommon, is my understanding. Do you think these survival pathways, PI3 kinase activation, would also be affecting the microvasculature? Could that be leading to some of that?
That's a great question. And in fact, we've got a whole group in my department that are concentrating now on MVO, microvascular obstruction and things like that, because that in itself is a reperfusion injury. And yes, the answer is we believe that conditioning can protect, but it's not ideal. We've got to find ways of actually, I mean, you probably see this in your patients. I believe X50% of them would have some microvascular obstruction. And that's got to be targeted, because that's very important. I don't know what's happened, but we've ignored that for many years. People have tried adenosine and this and that. None of those work. We are looking at it now. Again, I keep pointing to trying to find new ways to stop that obstruction. But that is it's another form of reperfusion that's got to be targeted.
Professor Derek, thank you. Excellent talk. I'm a surgeon. In my practical experience, I find shock patients with ischemia and reperfusion injuries. Can you demarcate between ischemic injury and reperfusion injury? Is there a protocol to demarcate ischemic and reperfusion injury?
Sorry, is there a protocol for what?
Demarcating ischemic and reperfusion. Which injury is actually causing the problem?
Oh, I see what you mean.
Yeah. Yes, sir.
Well, that's another good question, because you can't have reperfusion without having ischemia. So you've got to have ischemia. So the injury starts in ischemia. And so I think I might have mentioned, we've got to target the ischemic area as well as the reperfusion area. So there's two targets. But there's different forms of cell death in each area. So we're going to, we tend to ignore the patient or the animal that's ischemic, and we're looking only at reperfusion. But as I say, you can't have reperfusion injury without having ischemia. So there are definitely two targets.
Right, thanks.
Yeah, excellent talk. I was going to ask you, the PI3 kinase alpha agonist, you said you're now using this to look at stroke patients. How how does preconditioning work for people that are high risk for stroke? Have there been studies to show that that could also be protective for those types of patients?
First of all, we're not looking at but stroke, as I said, the pathophysiology of stroke is very similar. Stopping flow and open. And yes, you know, the second pathway, this pathway, the second pathway,
Clinical studies? Has there been any clinical studies done?
Now we're trying to, we have a multi-center study about the start in patients. It's not done, I'm on the committee, but I'm not doing the study. One of our northern universities looking at those stroke patients where we will put a cuff as they get into their stroke. But the most important thing they can get is from quite a lot now.
Okay, great talk. Just want to quickly ask you, do you think the timing of the remote ischemia matters? Because in preclinical models, the ischemia is given before cardiac injury, but in the clinical trials, you don't have that condition, right?
Well, I think that's
so you are giving
what Lars was saying about post conditioning. It has been shown that if you give the remote conditioning after, not before the ischemia, you can also get protected. So, you know, there's trials that looking at pre and post together. But right. And it's just that you've got to choose your patient population. I think others are very naive. You know, the patient that presents with an acute myocardial infarction is not the same as the animal that we use now. By definition, they all have probably have some form of atherosclerosis. We've looked at atherosclerotic mice, and we find that you can't be. So we've got to develop a prototype of that. And that is the second step. It's just
thanks.
Okay, Professor, then it's excellent talk. I have a very simple question. So during the preconditioning, so this procedure, so what happens to the immune system and also the oxidative stress in your heart? Because it's more systemic, right?
Yeah, again, I must say, brilliant questions coming up. You know, since COVID, we've learned so much about it. And we never took it too seriously. So complex. But I think the immune system starts now looking at if I thought what and but funny kidneys, what's a short breath? But yeah, we have to take inflammation and by definition technology much more seriously, but it's very complex. Here we are. I'm sorry.
Thank you for the talk, Doctor. I remember previously when we were involved in the study, like in 2015, we are using streptokinase for the thrombolysis. But nowadays we stopped using streptokinase because the kinase we were using for like 1 hour. Slowly we are giving. Nowadays we are giving tenecteplase. Is the study done the same?
Yeah, I mean, streptokinase. Oh, thank you. And as well as the Prime Minister years ago, So, 75. But there was nothing that they could use. And even from the license, what you do now,
You restricted this.
that is not instantly, but you still, it's better than nothing. And I know you have in Mauritius primary PCR, but that's not everybody can get it. And even we're working in South Africa, Cape Town, and Johannesburg, and there's certain private hospitals have primary PCR, but the massive population do not have access. And so thrombolysis is still used. So yeah, I think streptokinase was good in its time, but time to move on.
I'd like to come back to your comment about the role of inflammation. It has been shown for over 40 years or more. If you deplete complement, you reduce the reperfusion injury by at least the amount that you've shown with preconditioning. So how are these two different approaches maybe intermingled?
That's why I'm glad you also interested you and I are saying kids and you don't need cases. But like, and so you're on point very much. Nothing seems to be at all. And but it doesn't.
Good morning, everybody. Thank you, Professor Rhiannon and team. It's always a great pleasure to see you here in Mauritius. I don't have any questions, but rather an anecdotal comment, right? I don't know if you have seen watch all movies, all Indian movies. In all Indian movies, when the husband is sick, he lies on the bed, and you see the wife sitting by his bedside, pressing the leg of the husband. So I'm wondering now, whether at that time it was not a sort of preconditioning we're working about.
But even in Kenya, there was some clinical studies showing that patients with angina, they have I would argue quite simply that you're pressing the leg, or if someone having an angina attack, you've got to have a certain level of hypoxia, significant, and pressing the leg or having 30 seconds of angina is not. And that's been looked at in animals, not pressing the leg, but looking at short period, so short when they don't activate. I think that's a good time to stop.
So thank you, Dr. Professor Yellen. It's time to conclude the session. Thank you very much. Thank you, Professor. I would like to call upon Professor A.P. Singh to present the speaker, Professor Yellen, with the certificates. I would like to request Professor Klaus Priestner to come up on stage to present the chair with the certificates.
ladies and gentlemen, with this, we conclude the session 1. We have a coffee break for 15 minutes. I would like to request the core committee members and the local committee members to proceed towards the anatomy dissection hall for the poster viewing session. I request the faculty members to kindly proceed to the refreshment areas in the outdoor premises. The timings for the poster viewing for the college faculty will be during the high tea, that is at 3 p.m. Thank you.